The first AIDS meeting on the continent of Africa that was held by WHO, at least, and I'm not aware of any other meeting, was in 1985 in Bangui. Fakhri Assad asked me to set that meeting up, and I contacted colleagues at the Institut Pasteur in Bangui at the time because I knew they had a good facility for meeting and for organizing a meeting in those days. And so I worked with them to set up the meeting, and I thought it was a good place to have the international community because it would get the French involved. And the French, through their Instituts Pasteur, had and still have to some degree a very potent program for being able to really launch investigations in many countries on HIV, and they did that to some degree. So anyway, we organized, and Fakhri agreed that we would have the meeting in Bangui. And at that time, Luc Montagnier was involved, and he had already become very well known. So he helped he and his colleagues helped to set up, although he didn't attend the meeting. And we were able to get the international community. Now, there had already been an international meeting on HIV, but it had been held in Europe. And I felt that if we really wanted to have a meeting about AIDS in Africa, it needed to be in Africa. And so that was where we set up the first meeting. And many of the players, even today, who are still involved with HIV, came to that meeting in 1985. And that's where we developed the Bangui criteria for the clinical diagnosis of AIDS. As you might imagine, in those days, working in Africa, we didn't have, even though by 1985 there was a serologic test, you could do antibody tests and make a serologic diagnosis for exposure. Most of Africa didn't have access to this. This was new, and they didn't have access to it. So how are we going to count cases? What were the criteria? And one of the things that we did in that meeting was to sit down and hash out the so-called Bangui criteria for the diagnosis of AIDS in Africa. And that's been used for literally since then as a set of criteria, clinical criteria for being able to diagnose AIDS. And that helped in the overall effort to count cases because we needed to know what was the impact of the epidemic. So one of the things that came out of that, in addition to some collaborations and other things that happened, were these clinical criteria for the diagnosis of AIDS.
Yeah, I noticed in your book you said that was your main point to come up with.
Right.
With that,
right.
that clinical criteria.
Right. Mm-hmm.
Can you just briefly explain how does the Bangui definition work? Like how is it applied in terms of medicine?
Well, it's set up so that weight loss, and I must tell you it's been over 20 years, and I probably can't cite every single one of the criteria, but the idea was to say what would be a simple way for a clinician to look at a patient and be reasonably sure that they have AIDS. And one of them clearly was prolonged weight loss, an opportunistic, some kind of, and for there it was either TB or a fungus infection that was going to be obvious, that didn't require a laboratory to investigate it. And there probably were a couple of other criteria that were perhaps a little bit more minor that were involved. But the purpose of it, the principle was, how can you provide simple clinical criteria that you don't need a laboratory, you don't need a microscope, you don't need, that a doctor can look at a patient and say that this patient likely has AIDS. And that was the purpose of it. And among the major criteria was a severe weight loss and a evidence of some kind of opportunistic infection, fungus infection of the mouth, for example, or TB. Those were the major criteria for AIDS.
Well, in clinical terms, it just doesn't make sense. It is not helpful in any way. We are confronted frequently with sick people. That's our job, to treat them. In order to treat them in the best way, what we essentially need is to make the best diagnosis we can come up with, to treat them accordingly. And the diagnosis which is just giving another label to well-known treatable diseases doesn't help on treating these patients.
The people that came up with the concept of AIDS, they were able to conquer all of us. That's why I'm saying this is more a political stand, because it was a group of, I guess should be a group of engineers, you know, people that have been able to think of all these things and connect them so that they look so powerful, so that they look so unconquerable, so that they look so fearful, fierceful. You know, when you think of the word AIDS, it's as though it's this new thing that has just come in, that is more fashionable in disease terms. You know, it becomes even more scary.
In 1985, the World Health Organization held a meeting in the capital of the Central African Republic. Joseph McCormick was chosen to preside over that meeting. He's not African, he's not an African leader, he's a guy from the US CDC. What's he doing over there? Well, here's what he's doing over there. He goes over there and he says, we got to come up with a definition for AIDS. Now, why would you do that?
We needed criteria that were immediately available to clinicians and for public health people to be able to get some estimate of the number of cases they were seeing.
That was important because it allowed the African countries to start documenting the problem, and it gave something to clinicians in Africa to diagnose AIDS.
They could discover AIDS all over Africa at that point. They could say that we are all at risk, but they could say it's spreading around the world. They could say it affects women as much as men, because almost anyone in an African hospital could be diagnosed with AIDS without having to do the HIV test at all.
How were the official AIDS estimates created for Africa, and how credible were they in your opinion in the very beginning?
Well, in the very beginning, we had very little data. I mean, John Mann, based on his sort of studies in Africa and what data he had before the global program was even developed, he made an estimate of between 5 and 10 million globally, most of that in Africa. And when I finally got to Geneva in '87 and looked at the available data, I told John that at most I could come up with about 5 million based on what data was available and the assumptions.
5 million in Africa?
5 million globally. Most of that in Africa.
Well, you know, as Mark Twain said, there are lies and then there are damned lies, and finally at the very bottom there are statistics. And I think what he was referring to is probably quite old habit of statisticians of manipulating the data in order to show a conclusion that's preconceived.
So the Bangui definition, which is based on very unspecific clinical symptoms like fever, weight loss, or diarrhea or cough, these are symptoms which are widespread in poor countries where people suffer from diseases, well-known diseases, with exactly these symptoms.
You have diarrhea and you've lost a little bit of weight, and I also see that you live on a beautiful sewage canal where all your neighbors slaughter animals, throw their crap and their piss, and by the way, your kids play back there. And then you walk half a mile away, oh, it's 2 miles, I'm sorry, 2 miles away to a depression in the dirt that you draw murky water from, and you bring that home. And that's your water supply, and you bathe in that too. You have AIDS.
If America want to help Africa, or to see AIDS disappear in Africa, what they must do, give the people food, give the people clean water. After that, you won't see the AIDS in Africa. The AIDS in Africa is about poverty. That is the poverty. That's the #1 killer disease in Africa.
All the facts on HIV and AIDS with Griselda on Metro FM Talk.
It's World AIDS Day. There are functions, there are gatherings. The international theme is Stop AIDS, Stop HIV and AIDS. Keep the promise. So many years later, we keep saying the same things, HIV, 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 and yet
Africa does not have its own voice when it comes to response towards AIDS. Doesn't have its own messaging. Your multinationals, they don't even want to listen to the cries of African people. To them, it's more about, let's come up with this thing and define it as AIDS.
What is AIDS?
AIDS.
Yes.
I can't tell you much on AIDS. You see. Hence, this is the new language which has been brought by I don't know who. You see, I can't actually explain that. Rather than just knowing that people just simply say that AIDS is acquired immune deficiency syndrome, and maybe we will need a clear explanation from the experts that what is the meaning of AIDS. And if they actually say AIDS was not there previously, what were the diseases which were troubling the communities? Because these kinds of diseases were prevailing.
We did have patients with the conditions we now regard as AIDS defining, even before the advent of AIDS. Like we did have patients with Kaposi sarcoma, which is the skin disease that I was talking about. It doesn't necessarily mean that any patient presenting with Kaposi sarcoma has the virus.
Now, new ways, new terminologies have been brought to us. We are a little bit confused.
Daniel, a lot of people here is very sick and is very dying.
What kind of sickness do you see around here?
It's HIV/AIDS.
What is AIDS?
We don't know. We don't know.
There are cases whereby people are labeled as HIV positive when they have not tested, by even the health officials. Whether you're positive or negative, they don't even know. But then they just choose to label you because when they look at you, with those eyes that are hunting for somebody who's HIV positive.
You can't cough because coughing is AIDS. You can't lose weight because losing weight is AIDS. It's not muscle wasting anymore. You can't have TB, which is curable within 6 months because it's classified or packaged as AIDS.
You go to Africa, you go to hospitals, and you say, what is AIDS? And I said, what do you mean when you say AIDS here in this hospital? Kampala, Uganda, say, random example. They show you TB, they show you malaria, they show you sick, emaciated, weak, dying people. And you ask them, okay, but why are you calling that AIDS? And they say, well, we call everything AIDS here. It's a formula.
There was a Time magazine article about Africa with pictures of emaciated, awful people, and it said, more or less, look at these pictures and weep. Well, I come from Africa. I mean, I was born there, went to medical school there. My mother was a doctor in Zimbabwe, Rhodesia, then, where I grew up. And I can tell you that in 1940, I could take a camera and go around and make pictures equally as horrible as that. There's no HIV.
Oh, I'm sure it's true that not everyone who has AIDS has even had an antibody test, not to mention isolation of virus. But if you want to go do it, you could do it, but there's no reason. If it walks like a duck and quacks like a duck, you don't have to do a genetic blood test to see if it's really a duck. I mean, very soon you see what the disease is. You don't have to do a laboratory test on a lot of these things.
The Bangui, that's not a perfect, that's a clinical definition. That's not, people could have TB and not have HIV and fulfill the Bangui criteria. They'd lose weight, they'd have TB, and they could look like they have AIDS when they don't.
In a World Health Organization publication, Dr. Chin writes, "It should be emphasized that the surveillance definitions for AIDS were not intended to be reliable indicators of HIV infection."
Once you put so much energy, so much concentration on one thing, eventually you are legitimizing that thing. You are saying it is real, it is there, it is happening.
Do you think AIDS goes away if poverty goes away?
Absolutely. You take away poverty, you're giving people an ability to fight infections.
In Africa, the AIDS definition was established in '85. you know, a year after the official definition in the United States, although they were totally separate illnesses, you know, series of illnesses. Nevertheless, we decided that those people had the same disease.
Why in 1985 could we not apply the CDC's definition in the United States to Africa?
The level of laboratory and clinical expertise and facilities are just not present in the majority of African countries. So to diagnose histoplasmosis infection, to diagnose pneumocystis carinii infection, there's just no isolation methods for this. So to rely on diseases that had to be diagnosed by laboratory methods precluded really the use of that definition in sub-Saharan Africa.
Clinicians very fast realized the problems with working with this so-called Bangui definition, because a number of diseases have these unspecific symptoms, like diarrhea, infectious diarrhea, like respiratory infections or tuberculosis, which all of them are widespread in Africa. So in another African country, in Ivory Coast, doctors sat together and tried to improve the Bangui definition because they thought the Bangui definition had a poor outcome in clinical routine. And they came up with something called the Abidjan definition, which is kind of an amended Bangui definition. When countries adopted this Bangui definition, they adapted it according to their national needs. Some make it more strict, some make it less strict.
Different countries in Africa varied the Bangui definition?
Yeah.
What was the reason for that? Why did they all just use one common definition?
Again, I don't know the major reasons, but I would suspect that in some countries they felt they were a little more sophisticated than in others. And you have, you know, along with the epidemic of HIV, epidemics of HIV/AIDS experts. And some of them will not necessarily adhere to any international definition. They'll make up their own definition.
Just to give you an example, Uganda included in its definition for AIDS tuberculosis. So tuberculosis is an AIDS-defining disease. In Tanzania, they are using a more strict version, nationally adapted version of the Bangui definition. So instead of 3 clinical symptoms, they ask for 4 clinical symptoms. And as compared to Uganda, in Tanzania, they ask for an HIV test. Nevertheless, in one of the annual reports, the Minister of Health in Tanzania reports that only 33% of reported AIDS cases actually fulfilled these AIDS-defining criteria. Although 1,320 cases would not strictly qualify to be called AIDS cases, we have taken them as cases, assuming that those who reported them just made an omission at the stage of compiling the forms. Now, the Ministry of Health counts as AIDS cases even patients who have not even fulfilled the criteria of these 4 very unspecific cases, and they count them as AIDS cases and further continue to report them to Geneva, and then further on estimates are added for underreporting. A similar thing happened in Latin America when clinicians over there realized they had problems with working with the Bangui definition because of the poor outcome. So they came up with another definition based on clinical symptoms called the Caracas definition. All of them tried to find a way to diagnose what we know as AIDS based on unspecific clinical symptoms, while all what we know about AIDS is there are no typical clinical symptoms.
You open the New York Times and you see a story saying that 4 million Africans are infected with HIV. It doesn't imply that those people have been tested. It implies that they're linked via tortuous mathematical models to a woman who's tested positive in one of the sort of annual surveys conducted in African pregnancy clinics.
The three questions that we have to ask when we see statistics about AIDS cases or AIDS deaths or AIDS orphans in Africa are the fundamental questions we ask of any number. Number one, who created this statistic? Number two, how was this statistic created? And number three, for what purpose was it created?
Testing in Africa was never very important. The Bangui definition made it clear that AIDS in Africa was fever, diarrhea, weight loss, all endemic African problems. But you still want to put a good face on it. And you want to test. And the reason you test is so you can come out with startling numbers. Like there are 60 gazillion people in Africa who now have HIV and they all need drugs now.
What kind of big mistakes were made in early testing?
Well, this gets very technical, but the mistakes that were made is that people thought you could do the test with a single sort of control, that is a negative control, when in fact what you really had to do was to use each person's serum in Africa. Now this worked well. You didn't need all these controls in other parts of the country, in other parts of the globe. But in Africa, probably because people are exposed to so many parasites and so many different infections, they tend to have a lot of background in their serum that made this test falsely positive. And so there were some instances where people found, for example, there was one study where people examined blood from a group of children in the Congo and found 60% of them had antibodies to AIDS. This was actually published. And it was because they didn't understand the limits of the test and they hadn't used the proper controls, and so they way overestimated, and there were some other papers like that, and they had to be withdrawn eventually. But you can see that it created a lot of confusion because of that.
I'm sorry, what do you mean by estimates? I don't know. You said that the children, you mean estimating prevalence for the
Yes,
for the country?
yes. I mean, if you come in and say 60% of the children in this test were positive for HIV, I mean, that's a staggering number. We don't even have today any places with that high number. And so you can see, I mean, if somebody says to you 60% of the kids in the eastern part of the Congo are infected with AIDS, because that's what the antibody tests that they did said, I mean, you can imagine that would be pretty startling.
Some of the claims made about Africa, especially about the Great Lakes region, at a time when Peter Peart of UNAIDS would acknowledge the tests were totally defective and the predictions made were disastrously incorrect. I think that they traumatized the psyches of entire nations with claims that we now know are not right. And they never said sorry.